So good morning, everyone. Thank you for coming today, and we're very happy to welcome you here. Thank you very much. So before we start, I would like to pay our acknowledgement for the traditional custodian of the land. So we would like to acknowledge the traditional custodian of the land that we are meeting on, the Ngunnawal people. And we would like to pay our respect to their continuing culture and their contributions to the land and the society that we are living in. We also wish to acknowledge and welcome any Aboriginal and Torres Strait Islander participants who attend the event today. So before we start, I think that I'd like to introduce the purpose of our today events. So the purpose of our event today is to share information and knowledge across board about what or how allied health professionals and allied health assistants can contribute to the health and well-being of residents in our residential aged care facilities. So as you can see in the folder I have handed out earlier in the day, there will be agenda of today and the presentation and the slides for the presentation so that it's easier for you to follow the presentation and take notes. We will answer the questions at the end of all the presentations because we have the panel discussions. So please help me write down any questions that you have on the slides so that, you know, like we can take all the questions later at the end. And also, just some housekeeping. So if you need some time for the bathroom, please follow the sign over there. And in case of some emergency issues, our point for gathering is in the back here. Thank you very much. So may I welcome our first speaker, Stephen Isbell from University of Canberra. So Stephen will introduce about the role of multidisciplinary care in our aged care facilities and, you know, like how different allied health professionals can contribute differently to the health, well-being and dignity of our residents. Thank you very much. Please welcome.
Thank you, Kim. I'm just checking I'm not on mute. All good. Yeah. Thank you. So my name's Stephen Isbell. I'm an occupational therapist. I work at University of Canberra. I lead the occupational therapy program there, the Masters and the Bachelor's program. My clinical work has been in rehabilitation and in aged care. So my interest in aged care has been long-standing. And when I moved into academia, that continued. Last year, I was lucky enough to be seconded to the Department of Health. And they asked me to look at specifically some of the recommendations around allied health provision in residential aged care in relation to the Royal Commission. There's about 6 or 7 recommendations there, which specifically relate to allied health. And they asked me to write some responses to those recommendations. And the work that you see here today is partly the work I did at the department. And I'm really passionate about allied health because sometimes I know we are a little bit undervalued in aged care, and I think we have a great potential to improve the lives of people in aged care. So that's my motivation for today as well. So there are unmet needs in residential aged care in terms of allied health, and I know people here know that already, but the Royal Commission really highlighted a few facts. And a quote that really stood out to me in the Royal Commission was that only 2% of people in residential aged care receive the 22 minutes of allied health services recommended per day. That was shocking to me. And it's a real eye-opener for us to actually promote allied health into residential aged care. But the challenge is, and I know you all know this as well, is that the complexity of people in residential aged care is increasing as well. The care profile is increasing. And this graphic here just shows how, for example, in activities of daily living from 2008 to 2019, that care profile is increasing. People don't go into aged care anymore for a lifestyle choice. People like to be living at home. So when people do go into residential aged care, their care profile is a lot more complex than it was a little while ago. And that makes it much more, even more interesting to see that only 2% of people receive the allied health care that they need. So there is an issue here. But we can't take intervention as just the panacea of everything. There are other forces at play. So today I'm talking about intervention, particularly allied health intervention, but you can't divorce that from workforce or payment. So we can say that we need 10,000 more allied health professionals, but where are they going to come from? Who's going to train them? We can say we need another 10,000 allied health professionals, but if they're not paid properly in residential aged care, they're not going to come. So these three things we can't take in isolation. And I just wanted to mention that up front because today I'm really concentrating on intervention, but those two other things are really important as well. So what needs to be done? So most residents in residential aged care will have one of these three things. They will have dementia, they will be at risk of falling, or they'll be frail. So almost all residents will have these three things. And I won't read all the stats out to you here, but it's quite an issue for people in residential aged care. It costs a lot of money. Lots of people have these conditions and they are treatable. We can treat these things and we can slow the progression of dementia, we can prevent falls, and we can address the negative impacts of frailty. But it hasn't happened very well so far. The important thing to note is that there's been lots of work done, lots of evidence-based work done on all of those three things. We actually know how to intervene in these three things. In my opinion, we don't need many more randomised control trials to prove what interventions work. So my work at the Commonwealth really tried to highlight the fact that we have the answers to these things already, we just need to implement them. And implementation is a really hard thing to do. And one of the things we can do is look at reablement in residential aged care. And that's different from rehabilitation. Just let me give you the definition of reablement. It involves time-limited interventions that are targeted towards a person's specific goal or desired outcome to adapt to some functional loss or to regain confidence and capacity to resume activities. So it's not necessarily about getting better or rehabilitation per se, but it can be just allowing people to live the best possible lives they can in residential aged care. And there are multiple programs that have been proven to do this. And this slide shows some of them. And this is a great book from Hammond Care around reablement programs in aged care. And this forms some of the really good interventions that we could be doing in residential aged care. And importantly, on the right-hand side of this graphic is what allied health disciplines could be involved. What's often missing is that component. So this book actually specifies occupational therapy as an intervention. It specifies exercise, which physios and OTs and exercise physiologists can do. Falls prevention, cognition. There's a whole range of allied health professions that can be used to deliver these services in residential aged care. Now, in terms of frailty, there are, again, multiple guides available to treat frailty, not only from a medical perspective, but from an allied health perspective as well. And on the right-hand side of that graphic there are three really good evidence-based guides, including an Australian guide on how to treat frailty, and not only from a medical perspective, but again, from an allied health perspective. And really, simple things that we probably know already in terms of exercise, in terms of diet, in terms of keeping people active. All of those things allied health professionals can do, including occupational therapists, but a whole range of allied health professionals can do that as well. And again, these programs are out there. It just needs to be implemented. In terms of falls, this is a little bit different in that we know that falls can be prevented really well in the community. There's 3 or 4 very good evidence-based programs, falls prevention programs for the community but actually not quite so many for residential aged care, except early this year, Pip Logan from in the UK published her really interesting study about falls prevention, and she's published a really good guide called this Action Falls Guide, which she has implemented in the UK. It's cost effective and it works. It hasn't been tried in Australia yet, and we would like to do that. But this is a really good falls prevention program to use in residential aged care. So what we want to do as a research group at the University of Canberra is implement some of these allied health interventions into residential aged care. And we've applied for an MRFF grant and other grants, which we're hoping to get, which will essentially use a primary healthcare focus. So we're going to use a GP as a centre, and we're going to have allied health professionals supervising allied health assistants to implement these interventions. The interventions will be occupational therapy, physiotherapy, there'll be dietetics involved, optometry, and pharmacy. We'd like to have lots more allied health involved, but the cost of that will just blow out enormously. And our research will do a cost-effective analysis on this to see if it's actually effective, not only from the outcomes, like preventing falls, addressing frailty, etc., but also if it's actually cost-effective. And so we will hopefully consent some people in an aged care facility to be part of this program. We'll apply the allied health intervention and see if it works. And of course, that's all dependent on if we get this grant or not. The aim, of course, is ultimately to address those 6 or 7 recommendations in the Royal Care Commission in relation to allied healthcare provision. This is one model we think will work. And if we prove it works, hopefully we can roll it out to other aged care facilities in Australia. And I'm just going to finish on this again, just to stress again that intervention, which I've just talked about today, is just one part of this puzzle. We do need to work on workforce, and we do need to work on the payment of allied health professionals and other people into residential aged care. I've got some references there if you needed it, but thank you very much for your time. Cheers.
Thank you very much, Stephen, for a very informative presentation. So I hope that through Stephen's presentation, you have a general idea of how different allied health can support different conditions of residents in residential aged care, and that may help suggest or support your clinical care staff in the facility to work with the GPs on who should they involved into the care plan. So in the folder that I have handed out earlier in the day, there's a flyer of Occupational Therapy Australia, and in the back there's some suggestion for funding options for not only OT, but OT in specific, but also can be applied for other allied health professionals. That is a GP management plan. So if the clinical staff can understand the needs for allied health for different residents and for different conditions, they may be able to advocate for the facility GPs to arrange a GP management plan so that can help the resident access allied health. So yeah, that's just one of my 2 cents from the presentation that I would like to share. So coming next, second presentation is the presentation about how allied health assistant workforce operate or can support the aged care sector, delivered by Andy from Canberra Health Service. Welcome, Andy. Thank you.
So good morning, everyone. Yeah, my name's Andy Richardson. I'm the current profession lead for allied health assistants within Canberra Health Services. I actually started as an aged care assistant in aged care almost 8 years ago now. And then with the work I do now with Canberra Health Services, we've done a lot with our subacute older persons within 11A, 11B. So I've seen both facets of the benefits of rehab and assistance within this aged care bracket. And I'd just like to run down a couple of ideas of what we think could be beneficial moving forward. Okay, so just a rundown as to what my role is and who we are. So an allied health assistant is someone who assists an allied health professional with clinical and non-clinical workload in order to be able to free up an allied health professional to work on more complex tasks. So normally the way this is set up within CHS, that it can within the aged care sector, is the initial screening of one of the residents will be done by the allied health professional to be able to put a plan in place, no matter what allied health discipline that is. And that plan can be implemented with the allied health by the allied health assistant, being able to feedback every now and then positives and negatives of what might need to change. The supervision of this from the allied health assistant can either be done direct, indirect, or remote, depending on the setup of the facility itself. Oh, sorry, I'm supposed to be looking that way. The allied health assistants have their own scope of practice by which they follow. That framework is currently already done by ACT Health, and we can submit copies of that particular document if that was to assist anyone as well. And all the work performed by the allied health assistant is delegated and performed under our supervision agreement. Now we've attached a copy of this as well. This is a very good and important reference point for everyone to be aware of, because this particular document spells everything out from how the facility itself can delegate specific work to the allied health assistant, what specific things will count within their role of scope of practice, and what can't. Okay, so the main purpose of this framework, as I was saying, a better understanding of what an allied health assistant can actually do as part of patient-centered care, a better understanding of the delegation of the AHA, and then it also gives framework of, depending on the level of allied health assistant that you were to employ, what they could actually do within their scope. And if you have any questions on that, you can fire them at me later. Okay, so the main goals of care within a residential aged care facility. So we want to try and reduce the amount of current manual load on the existing care staff. Working in an aged care facility, I can see myself, there's times with the residents themselves require a lot of assistance, whether that be manual assistance with the assistance of transfers and mobility practice, or just unfortunately a little bit more dependency. So just on tasks such as, preparing themselves in the morning, getting themselves dressed, all those common things that we completely take for granted. We want to make sure that we promote the independence of the individual. I always try and make sure that we do that no matter what we're doing. They're a person, we need to give them the independence and the dignity that they require. We don't want to create unnecessary dependence on the aged care workforce that already, as we already know, is very, very short is not the wrong word. Exactly. We could always require more assistance, and this is one way to be able to do with it. And dignity, I saw this and I absolutely love this. I thought it makes a lot of sense. Without dignity, identity is erased. In the absence, we are defined not by ourselves, but by the environment in which they live. Being able to promote the dignity and the independence of every resident, no matter what they do, should be the key to the healthcare that we're trying to provide. And the way that we try and do this currently within CHS, for example, is by trying to regain that dignity and that independence in smaller ways. So first, allowing them independence within their bed space, or limit the amount of assistance that they require so that they have a little bit of onus on what they do and they try and gain a little bit of that dignity back. Okay, the benefits of our workforce. We're a little bit cheaper than the allied health professionals, a little bit more cost effective. And the most important thing is we are multidisciplinary. We have the benefit now that the wonderful institutions like CIT, the TAFE, not only graduate students that have a single discipline skill set, they normally graduate with more than one. Now, the potential for this moving forward is fantastic. I was employed primarily as a physiotherapy assistant, so I only did all the general physio things. So the exercise groups, the individual exercise programs, the strength programs, that was what I did. You think of the potential of having a single allied health assistant who has skill sets in occupational therapy, physiotherapy, the way that you can break up the particular week of just one AHA within a residential aged care facility, and potential is ongoing. Our AHAs within CHS, when we started and the role of an allied health assistant was established, it was only 10 years ago. When we started, there were only 34 allied health assistants within ACT Health. Now we have over 130 allied health assistants within Canberra Health Services through 16 different allied health disciplines, and another 30 or so with Calvary Health Services. So we're a workforce that's still growing, and there are lots of us. Currently, at the moment, CIT graduate between 15 to 30 AHA students yearly, and they're not all employed by us. So there's all of these students that are graduating with these qualifications that still have somewhere to go. Okay, so now we can go through specific skill sets of how each of these AHAs can benefit the residential aged care facility. So physiotherapy, so like I did myself, running regular group exercise classes. When I was working in residential aged care, we had 2 specific 30-minute exercise classes we do daily. One for the general population, and then one specifically for the dementia ward. Both exercise classes you'd have to tailor differently depending on the type of residents they had. You have your individually tailored exercise program. So whether that be for benefits of strength, benefits of balance, most important one, specialized mobility practice. So for those patients that may have been unwell, have had a reduction in their mobility, giving them more specific training within their bed space so that they become safer to be able to get themselves out of bed in the morning. They could safely walk from their bed to their bathroom, to be able to reduce that amount of assistance by the residential aged care staff. Nutrition, under nutrition, the allied health assistants can assist with supplying supplements to the residents if they require it. They can review their weight. They can provide support at meal times if they require that additional bit of assistance. They can coordinate group activities like healthy eating classes, coordinate growing vegetables in the garden and how to be able to implement and use them within cooking within the facility itself. Assist the chefs and the dietitians at creating a more healthy menu for the residents depending on dietary needs. Podiatry. So we have very few podiatry allied health assistants within CHS at the moment. We only have 2, but the 2 that we do have are highly specialized. And some of the tasks that they can do as part of the role itself is, your basic nail care. So being able to cut nails, foot health, adjust standard orthotics. There's so much potential for them in this space. I've completely lost my occupational therapy slide. I don't know where it went. But to our occupational therapists, the wonderful things that they do, that the residential aged care facilities, the main benefit of occupational therapy within the residential aged care facility is such things as the assisted devices with activities of daily living. So that could be pieces of equipment specific to assist with dressing, bathing, being able to go to the toilet, things that again can give independence and dignity back to these residents. Just the ability to be able to put on their own socks and their own shoes in the morning might not seem like much to us, but it's a wonderful thing to look on the way forward. This generation at the moment, they're the baby boomers. So we know that it's going to be a large demographic, and the demographic is only going to get bigger. These are our aunties, our uncles, our mothers, our fathers, our grandmothers, our grandfathers. We need to show them the same dignity and give them the same care that they showed us when we were growing up. Thank you for that.
Thank you very much, Andy. And I think that is a very fantastic presentation about allied health assistant, who is the emerging workforce in the ACT, and like some supporting materials and documents that can help facilities, GPs, and other practitioners understand more about the scope of practice at of allied health assistant and can engage with the workforce more to somehow alleviate the current workforce strains that happening in the facility. Thank you. So welcome next, our Elizabeth for dietitian.
So good morning, everyone. My name is Elizabeth Lowe and I'm an accredited and practicing dietitian. My area of specific interest is actually looking at what it takes to keep older people who are living in the community eating well. And so for that reason, I'm actually undertaking a PhD at the University of Canberra, looking at the effect of social isolation on diet quality for older persons living independently and in the community. Now I can see some eyes already glazing over at the mention of the word dietitian. So let me just reassure you that I'm not going to speak at all about kale, lentils, quinoa, or any of that really nutritious stuff. What I do want to briefly talk about is the role of dietitians in aged care, the role of diet quality in aging, and where a dietitian can actually make a difference. Okay, so just to set the scene a little bit, in 2019 and 20, there were 1 million Australians who used aged care services. And that was either through home care packages or residential aged care. Now, about a quarter of those people are actually in permanent residential aged care. And as you can see, most of this group are in the old age category, being over the age of 85 years. So Stephen mentioned earlier that allied health professionals and allied health services are underutilised. And he mentioned the 2% and 22 minutes figure. Now, this sort of figure is actually reflected in the general community for older people as well, with very few people using their home care packages to fund allied health services. And by not having that sort of support, there is a tendency for them to actually be that little bit more frail, that little bit more unindependent, needing support by the time they actually do enter residential aged care. So, what is a dietitian? So it's important to note that all dietitians are nutritionists, but not all nutritionists are dietitians. To be a dietitian actually involves completing an accredited tertiary course, usually 4 years undergraduate, or a relevant 3-year undergraduate course plus a postgraduate course. For example, the University of Canberra offers a Masters of Dietitian and Nutrition and Dietetics. Then they're required to have credentialing through Dietitians Australia. Only dietitians who are part of the accredited and practicing dietitian scheme program can actually provide Medicare and Veterans Affairs rebatable services. So what do we do? Well, we do a whole heap of things, but specifically in aged care, there is a comprehensive scope of practice for dietitians that has been developed and is contained by Dietitians Australia and is contained in the older people and aged care role statement. And this is actually published. Now, as you can see, there's a lot there. And in fact, I have a second slide because it is a very encompassing and comprehensive role statement. Some of these things that we do have an asterisk next to them. These are the roles that we also would be looking to fulfill with some priority for our clients who are actually in the community setting. I'm just going to highlight 3 of these that I think are really important, and the other dietitians that are here may actually have some other ideas, but specifically I like these ones. The first is malnutrition assessment and screening, and that involves using a validated screening tool or a validated and appropriate assessment tool. The screening and assessment gives us an excellent opportunity to get into that whole prevention cycle and to assist and promote and maintain good health. Supporting food services through a food first approach is crucial. it's a much more pleasant experience for our aged care residents if they can eat beautifully presented food rather than relying on us trying to get things like resource into them, which if any of you have tasted resource, it's absolutely disgusting. But food first approach is really important. And possibly the most important one of these here on this slide, that's working collaboratively within a multidisciplinary team. And I cannot stress enough how important that role is. As I said, there's still a little bit more. The bottom two of these specifically relate to how we can assist residential aged care providers at the organisational level. So, just before I start to wax lyrical about the role of diet and quality ageing, I just wanted to show you this amazing diagram showing the biological pathways mediating the relationship of diet with cognition, and that's from July's Lancet. So I'm sure all of you have read the Lancet cover to cover because you've all got lots and lots of time to do that. But just on the off chance that you haven't managed to complete that, I thought it was really worthwhile having a look at this because it really nicely highlights the role of diet in the three areas of factors that are categorised here. So first is the obvious area of behavioural and contextual factors. Next is in the systemic factors where the important and known role of diet is highlighted for managing and preventing vascular and metabolic issues listed here. If we have a look, you'll see that inflammation is actually mentioned in both the systemic and brain factors columns. There is an emerging body of evidence around the link between diet and the tendency for the aging body to move to an inflammatory state or inflammaging. This work shows that food can elicit a pro or anti-inflammatory effect on the body, with physiological impact being measured by the increase and decrease in inflammatory markers. And those inflammatory markers are primarily interleukin-1, interleukin-4, interleukin-6, interleukin-10, TNF, tumour necrotizing factor, and C-reactive protein. All of this work has actually been translated into practice, and there is actually a dietary inflammatory index which has been developed and can be used to determine whether a person's diet is pro or anti-inflammatory. So, back to some basics. Just a few years ago, or maybe more, Hippocrates recognised that food can have medicinal quality. And while we all may hold differing beliefs as to the extent that foods hold medicinal qualities, there can be few who would argue the importance of diet in the management and prevention of, for example, non-communicable disease. There's also a substantial body of research that shows that diet and nutritional quality plays an important role in quality and healthy ageing. Additionally, diet is recognised as one of the more readily modifiable factors when looking at factors that can not only extend life, but extend healthy, active years. It's probably also important to just think about what we mean when we talk about diet. So the word diet actually comes from an ancient Greek word, dieta, which means a way of life, and one still practiced in many Mediterranean countries. On its linguistic journey through Latin and Old French to English, dieta's meaning has become narrowed to the sorts of food one regularly eats, or a particular eating regimen, usually a restricted one. But realistically, diet is more than this narrow meaning. It's more than nutrients, and it's more than just the food that makes our way to our mouth. All right, so you're going to have to just put a picture in your mind. In this hand, we have stressors. So stressors are things like age-related disease, other diseases, nutritional frailty, risk, potential and actual frailty, psychosocial, socioeconomic, and cognitive issues. So they're all sitting in this hand. In this hand, we have enablers such as healthy eating, well-being, physical, cognitive and financial, social connectedness, family and community. So what forms and influences our diet is much more complicated than meat or plant-based substitute, and 3 veg on a plate. What and how we eat is a balance between enablers and stressors. And each of these is going to vary in influence and importance by individual. People can be food secure but malnourished. People can also be overweight and malnourished. And it's not just, this doesn't just happen in the residential aged care setting. Interestingly, while we have significant data on malnutrition risk and actual in the residential aged care setting, there is very little for older persons who are in the community setting. For this group, estimates of malnutrition in the literature can range to 5 to 35%. Maintaining a balance between stressors and enablers is always important, but more so as people age and the risk of nutritional vulnerability increases. Sorry, it's not on that slide. The interactions between healthy eating and age-related psychosocial and physiological challenges are often underestimated and underappreciated. So our current ageing policy is framed around the concept of ageing in place, at least for as long as possible. For residential aged care, this often means that new residents are already unwell or frail or in varying states of cognitive and or physical decline and very nutritionally vulnerable. And while there is an imperative to treat obvious and immediate and critical physiological and disease states, we need to also keep in mind other factors as we help this person to become much more well and get them ready for re-enablement, as Stephen was saying. Okie dokie, that's here. So in my clinical work, the last thing I want to hear from older clients is, I'm just not hungry. The importance of maintaining adequate nutritional intake for older persons cannot be stressed enough. And this is where dietitians and the role statement that shown earlier come very much into play. Once older persons become malnourished and or frail, the flow-on effect is significant. Sarcopenia, increased falls risk, lowered immune states, poor wound healing, poor glycemic control for those with diabetes, macro and micronutrient deficiencies, particularly protein. Prevention over cure needs to be a priority. However, often it isn't as simple as just telling patients to eat more or prescribing some supplements. For example, using loss of appetite. Loss of appetite can be really tricky to resolve, and it's important to keep in mind that the cause may not always be physiological. Once obvious physiological causes are ruled out, finding the cause can still be elusive. It could be as simple as Mrs. Jones is missing spiced foods from home and finds the meals in aged care are too big, they're bland, they're tasteless. It could be that she hates sitting next to Mr. Gray, who just drools or tells the same story over and over and over, not that that's Mr. Gray's fault. Or maybe she's got COPD and is just tired from coughing and simply doesn't have enough energy to sit at the table. Or maybe it's her medications. Using mealtime as the time to give residents medications may have operational efficiencies, but it is well known to negatively impact mealtime experiences and can reduce food intake. Swallowing the pills is unpleasant, or they feel nauseous after taking the medication. All of this reduces nutritional intake, which ultimately impacts good health and quality aging. So as you can see from this slide, the causes of I don't feel hungry are many and varied, and this is not an exhaustive list. But once the cause is identified, we really need to work on finding a solution. It can be made more complex by that individual. What if the resident also has renal disease or is on fluid restriction or has poor glycemic control? What if they have wounds that are slow to heal, cancer, cachexia, dysphagia? Medications. There are a number of food-drug interactions. Leafy greens with warfarin are a classic example. All these situations need their own tailored solution. What works for Mrs. Jones won't necessarily work for Mr. Gray. Importantly, these are all situations where dietitians can provide valuable services. Quite simply, this is a part of what dietitians do. It's here that dietitians can be a valuable part of the residents' care team. GPs and specialists are ridiculously busy and their patients know that. Residential aged care staff are also busy and the residents know this too. Dietitians are also busy, and food and all of its complexities are our business, and more importantly, they are our passion. Working as a part of the residents' care team and with other allied health professionals, we can all do our part to promote healthy and quality ageing. So thank you.
Thank you very much, Elizabeth, for a very detailed and beautiful presentation. One of the things that I really like when I discuss with Elizabeth about the direction of today's presentation is that meal is a social experience. There's a lot of things that impact a meal experience that can lead to, like nutrition intake and also, ability of the person to enjoy their meal time. So thank you very much. So coming next for our presentation today is presentation from our psychologist, Max, coming from our next step in residential aged care program. For those who haven't known about next step, so next step is our mental health support or services delivered for residents in residential aged care. And Max here as a psychologist working with that service from the commencement day will share with you the very practical on-site experience of the mental health challenges and the service capacity to actually can help the residents in residential aged care. Thank you very much and welcome, Max.
All right, good morning. Lovely to see so many people here to talk about this when it's so frosty outside. There's 4 things I want to talk through with you guys today. The first is the scope of our program. We're not the only mental health service, and what we do is something that's both specific and generic and designed to deal with the majority of distress, but is not the end all to every problem that comes up. The second is what we're trying to do going into aged care facilities, why we're doing that, how we're doing it, and then 2 things that are challenges that we're trying to adapt to. So firstly, next step, we provide a CBT for anxiety, depression, and PTSD. It's a brief, intensive intervention. So generally we're looking at 12 to 18 sessions. They're provided weekly, if possible. Sometimes it's fortnightly. We do have to flex around that. But the idea is we're identifying a problem, we're establishing some momentum, and we're getting that problem sorted. Those sessions are frequent over several months, and we actually provide services from 0. I don't think we've had anyone under 4, but officially 0, all the way up to as old as people get. It's a 2-tiered program. So we have a level that you can self-refer into. It's the services provided by coaches who are trained up by psychologists to deliver specific therapies. And then the high intensity level is delivered by psychologists who are assessing people on an individual basis and providing a more personalized approach to their problems. So the reason I wanted to talk about the scope of our program is it's important to understand that, like most therapies, CBT is an active approach. It requires effort, it requires engagement, both in the session and between sessions. Most of the function of CBT occurs around behavior change, whether that's behavior in terms of dealing with thoughts differently or whether it's literally doing some things differently. And that takes quite a bit of, that can be challenging for some clients. So the most effective in CBT interventions, CBT standing for cognitive behavioral therapy, probably should have led with that, work through building some skills, building some techniques, building the ability of a client to apply those eventually independently of the therapist. The reason we've tried to roll out this program into aged care is we found there were some significant barriers for aged care clients coming out and engaging with our service. Those both occurred around mobility. It took a lot of effort for some people to get out and see a service, and also around technology. Telehealth only goes so far. And when you're trying to use interactive whiteboards and collaboratively doing things on computers, it wasn't always going well, especially with the limitations around aged care staff helping residents with technology. As well as that, there were difficulties with trying to schedule, trying to arrange transport. because of the number of residents and the relatively small number of staff. So as a result of that, we've gone out into facilities. We're trying to create spaces where we can provide sessions, and at times we're providing sessions in rooms, though obviously that's something we try to balance because we're going into someone's home, we're going into someone's space, and that can make the dynamic of therapy a bit difficult. The other significant thing we're trying to address there is often with older residents in Australia, there's a degree of stigma around seeing a psychologist. That can be from a whole number of things. They might not have psychology in the 1930s is very different to what it was today. And that legacy can be intimidating for people. It can be that they have never had experiences of talking about some of these things, or they come from a culture where talking about your feelings is a bit different or a bit taboo. So another thing we're trying to do is provide a degree of a sort of warm referral route where they can come in and have a bit more of informal chat. There's less pressure to sign consent forms, and where we're trying to set up things like groups where we can talk about some of the principles of CBT, some of the principles of looking after your mental health without the intimidating, please lie down on my couch kind of vibe. We don't use couches anymore. There have been some things we've found difficult though. The first is the barriers to applying interventions. Aged cares don't have unlimited resources and they have to try and use them in a way that benefits the most residents, but this leaves significant gaps. And this has just been compounded by COVID. As I was saying, CBT is an active intervention. And towards the end of therapy, you're looking for people to challenge themselves in ways that can be quite difficult. That might be someone who's socially anxious and you're getting them to go out and maybe make a few mistakes and see if other people notice, see if it's embarrassing as they think. That might not be something that's easy to do in the dining room of an aged care. It's a big, loud, busy atmosphere. But getting the resources that they can go out to a small cafe, be supported by a friend and practice that kind of exercise, it hasn't always been possible. And this stalls progress. Another thing is a lot of therapies talk about trying to create meaning, trying to help people engage in activities that feel productive or feel like they're contributing. And this is something aged care people we really like to encourage. It's things like them sharing knowledge, sharing experience with someone who might be younger. It's things like getting involved in community work, recognizing that you can still be helpful, even if it's not at the pace of someone young and fit like me. No. These things are very difficult when you have the differing needs of residents in aged care. And often the activities the aged care is running is designed to be accessible to everyone, but as a result does not provide sufficient challenge to residents who might be feeling depressed and are looking for something that pushes them or that helps them develop that sense of meaning. As a result, we often find we get in, we do some early intervention, it's very useful, things improve, but there's restrictions, make it difficult for us to facilitate tasks that go to that next step, that help us finish off treatment, that help us reach a level of recovery that's more lasting. The second service issue we're finding is about the referrals we're getting. It's sort of a twofold issue. The first problem we see is often some residents get overlooked. This isn't something that's on the slide, but it's something that occurred to me having some conversations last night, but I think it's important to talk about. Often the symptoms of depression and anxiety can make someone really easy to look after. They're withdrawn, they stay in their room, they don't make a fuss, they're very polite, they're very cautious to put too much of a burden on staff. And as a result, the staff don't think anything's wrong. And this is something that we can remedy by educating staff and by having that opportunity for residents to self-refer or for residents to know this is someone I can talk to about something that's going on for me and they can give me some options with this. The second issue we're finding is a lot of the time the referrals are in response to problematic behavior. And this doesn't mean they're not eligible, that we can't support them. Depression and anxiety can include symptoms of confusion, of irritability, of not wanting to do anything, of being quite disgruntled, of being hostile. But those things can also be related to cognitive decline. CBT, as I was saying, requires active engagement, both during and in between sessions. And when a client has limited recall, has limited insight as to what's going on with them, this can be a big barrier to them engaging in this kind of therapy. So with these clients, we've tried to do a few things. There's a limit to how much we can support them through the techniques we have available. But what we have been trying to do is create brief support plans, talking about how these people are experiencing distress and what might be maintaining it. This isn't something we can get these residents necessarily to engage with on their own. Where we can, we do, but often it's reliant on staff, it's reliant on supports to start noticing these patterns, to start noticing when a client's becoming hostile, and helping them to challenge those thoughts in the moment, helping them to sit with that distress, because we know that creates long-term reductions in these problems. Where this becomes difficult, though, is the challenges to staffing in aged care. There's a lot of different staff. You regularly have the same staff seeing the same residents. And in general, there's limited time for them to discuss and understand and then implement these kind of approaches. The other thing is this is not something we generally cover in our training. Behavioral support is a whole discipline of psychology. It's a specific skill. And we're pretty good at adapting these principles of CBT, of coming up with ideas, but it's not to the scale that we'd really like to deliver this kind of service. And it's also something that when it's implemented in the best way possible, it's implemented as part of a team. It's something where there's oversight, there's consultation. These things are being tested, are being tried, and then there's some feedback and the plan is adjusted. So that's a significant gap that we're seeing in what we're trying to do in the aged care facilities at the moment. So that's the 4 things I said I'd talk through. Really look forward to some questions later on. And as I said, thank you for coming out here, guys.
Hi everyone, my name is Shiva. It's lovely to be here and thank you for inviting me here today. Firstly, just Stephen, thank you. You've set the scene really well for us as allied health professionals. I think the key takeaway there is that all of us allied health professionals, as well as our medical officers, we all have different lenses in which we see our older people. And by viewing older people through various lenses, various expertise, we can really optimize the care that we're able to provide them. So I've been in aged care for many years, since 2005, working as a physio and currently look after physio and lifestyle services for a not-for-profit organisation called Warrigal. I'm also sitting as the New South Wales Gerontology Chair for the APA at the moment as well. So that's boring, so let's get into the good stuff. Okay, so to set the scene, I guess when I came into aged care, we had physiotherapists coming in to the aged care home that I was at. They were attending once every week, maybe once every 2 weeks for a couple of hours, coming in, and they were doing assessments and then providing some prescriptions to therapy assistants that were not qualified, that were usually return to work people or lifestyle staff that were doing it as something to do. So what's changed and what's happened over the last number of years has been the aged care funding instrument. So that tool has been around for a while, and a lot of allied health professionals hate this tool, and I'll talk about why in a minute. But the benefit, or what the tool has allowed for physios and OTs, is actually a foot in the door and an opportunity for us to demonstrate some of the skills that we have and really optimize some of the care that we can provide to older people. And it's also allowed us an opportunity to upskill and actually have allied health assistants, qualified allied health assistants, and programs to support them with their development, their knowledge, their growth, to be able to apply that so that they can be another set of eyes and ears on the floor to identify when changes are occurring and also to support with those programs. So what is ACFI? So ACFI is a funding instrument that is currently in residential aged care, where it's split into 3 key categories, where we've got aids to daily living, we've got behaviour and complex health. So I'm not going to go into too much detail, but basically the reason why there has been an increase in physio and OT services in residential aged care is because by us providing services or delivering treatment to an older person, the aged care provider has been able to claim back money from the government. That is about to change. So some of the limitations about that program is it was scope limiting. So through complex healthcare, we were able to claim back funding or a level of funding for us putting our hands on providing massage therapy or technical equipment as a service to older people. Initially, when we rolled out that program, or when the government rolled out that program, there was no time limit. So we did have a number of providers and services out there that were effectively rorting the system. And that's been a huge negative reflection, but we do have some providers out there which were actually doing some really great work and using this as an opportunity to affect some real positive change in residential care homes. So what I mean by scope limiting is we had, right now, you've got 20 minutes where you have to deliver services, and the service that you're delivering is determined by the funding instrument. So that has actually de-skilled or taken away some of the ability for some allied health professionals to be able to use their clinical skills and judgment, because some providers are trying to add people to the program, not necessarily because of need, but because it's going to have a positive impact on funding. So that's been the terrible thing about ACFI. The positive thing, once again, is that physio OTs have been able to get a foot in the door, and some providers have actually used this as a wonderful opportunity to actually provide some amazing services. So for our organization, for example, what we've done is we've got exercise programs happening daily, individualized therapy. We don't just do ACFI, which is massage and technical equipment. There's still individualized exercise, rehabilitation programs, and things incorporated as part of the process. So it's really trying to look at things holistically, and allied health has been embedded into the way we work. So the physios are included in falls prevention, included in WHS processes, and a whole bunch of elements of things that can occur in residential aged care. The problem becomes with the new funding instrument, which is due to occur in October 1, is that there is no longer any direct funding related to allied health. So that means that the funding pool is provided to the aged care provider, and the aged care provider can now determine how that funding is being utilised. So with the change in funding, there's also some guidance on ratios for RN nursing staff for care, but there's no ratios or determination on what level of support may be required by an older person for allied health. So this is one of the limitations behind the model, but the positive things are that the resources that were spent assessing and internally assessing the resident no longer have to do that for the sake of funding. So you no longer have providers that are actively trying to maximize funding. You now have an external person or people or group that will come out and determine the level of funding based on some validated tools. So the positive thing about that is that the residential care providers, allied health, can actually no longer worry about funding. They are now looking at what the resident, the customer truly needs, which is great. So what do physiotherapists do in aged care? And I think Stephen touched on a number of these things, but I think the key thing, once again, is having another pair of eyes from a different clinical lens to add to the repertoire of what we offer to older people, more than just RNs, more than just OTs, more than just physio, more than just dietetics. It's all these scopes together to be able to look at a resident holistically and offer the best services to the individual requirements. So we do falls preventions. We've got a number of management programs that we can run. We are embedded into, we've got some great skills in WH&S prevention, looking at pressure area care. We support with basic equipment prescription. Obviously, our OTs are more skilled in that area. We do have some behavior tools and things that we can apply as well, which is great, especially for residents living with dementia. I think it's probably an underutilized area of physiotherapy, but being a part of that discussion for an older person, especially with someone living with a dementia, having a physio or OT input from that lens or that perspective from falls prevention can really make a difference. Just gonna move on here. So what can you guys do? So I think one of the key takeaway messages from today is get an understanding of what opportunities are available for the older person in their community. Having access or the ability to engage in opportunities in the community can really benefit them. A lot of our older people, especially with COVID, have been suffering from isolation, loneliness, and disconnection from their community. So sometimes coming in as a healthcare provider and having knowledge of what might be available and trying to connect them to those can really provide a great benefit. I think the other thing is also considering when you're having your discussions or you're doing your medical interventions, or sometimes you get these gems of information about who the person actually is, what their motivations really are, and how and by knowing what's available in the community and or available by the aged care provider, you can actually help support those connections to those things. I think that's one thing that a lot of allied health professionals do really well, is finding the internal drivers, those internal motivations, creating some goals, and actually giving some older people some purpose, something to drive for, something to strive for. And I think that's become more meaningful than ever before, because those family members that used to visit daily are now visiting weekly. Those family members that used to come once a week are now coming every month. You know, this is just what's happened with the nature of COVID, the restrictions, and I think everyone's suffering from a bit of COVID fatigue. But I guess thinking about it from the perspective of the older person and their connection to their loved ones and their community, we are part of their network that we can help support, connect them to things. So some of the programs, or having knowledge of some of the programs and supports out there, you can help support that connection and facilitate that ability to have that drive and that purpose, and that, because once they lose that drive, it's a spiral downwards, and we need to be able to continue that motivation. So one of the ways in which you can support is the use of those enhanced primary care directives, thinking about what is really important to that individual and which allied health professional or group is able to best meet that need, and trying to connect them with that as well. So if you do want more information, or if you do have questions from a physio perspective, there is that email there, and my email address is at the end in your pack as well. So thank you very much for your time, and hopefully you got something out of that. Thank you.
Yeah, thank you very much, Shiva. That is really great. And I totally agree with Shiva at Shiva talk, like all Shiva presentation properly. But at the end, I think that experience shared across all allied health professionals who have contact with the residents, and you know that is knowledge to share, of course. Coming next is our presentation from Jane, from the Pharmacist in Residential Aged Care Study Team. That is an initiative that residential aged care employ pharmacists to help support with medication review and further. So please welcome Jane for the presentation.
Thank you for introducing me. My name is Jane Kerner, and I also have my colleagues Miranda Batten and Ibrahim Haider from the University of Canberra, and I'm going to talk to you about medication management in residential aged care, and specifically about our study. So the chief investigators on our study, Sam
Kosari and Mark Naunton. They are pharmacists, and they are not here today because all the pharmacists are at the PSA, Pharmaceutical Society of Australia conference in Sydney. I'd like to acknowledge that the study is funded by CHN, and thank the residents, facilities, facility staff for their involvement in the study. So the current study that we're conducting is a randomised controlled trial and an implementation study looking at how employing a pharmacist in a facility for 2 or 2.5 days a week can improve resident level and facility level outcomes. So I'm not going to go through all the outcomes because there are a lot of them, and there is a protocol paper that has been published. But basically, the study is looking at reducing inappropriate medications, including psychotropics and chemical restraints, reducing emergency department visits and unplanned hospitalizations, falls, medication incidents, increasing education to RAF staff around medication management individually and as groups, improving policies and procedures, and increasing collaboration with GPs, prescribers, and other healthcare professionals. So the study builds on a pilot conducted in Goodwin a few years ago, which found high rates of acceptability, increased flu vaccination, and reduction in inappropriate medicine dosing, such as crushing of medications. So just to give you a very brief summary about the issues regarding medication safety in aged care. So due to the comorbidities and age of residents in aged care, residential aged care, people take a lot of often quite risky medications, and this can really lead to adverse outcomes, including unplanned hospital admissions and arising from inappropriate medicine use. So the Royal Commission into Aged Care Quality and Safety also focused on the inappropriate use of psychotropics. So generally, RAF staff, RAFs are facing understaffing, and there's an identified need for upskilling in medication management knowledge and skills. And I think that RAFs are reporting that under COVID, there's been a lot of turnover of staff, there are staff shortages, and there is a different staff. The background of staff has changed from people who were undertaking tertiary qualifications in aged care. Now there is a tendency for there to be more students who are perhaps studying IT or another discipline who are working in aged care just on a part-time casual basis. So there are existing RMMR and QUM services funded by the Commonwealth Department of Health, but given the issues that I've highlighted, it seems that these current services are not sufficient to address the scale of the problem. So, this is an overview of the on-site pharmacist role. So given the problems that I've just highlighted, what we are proposing in our model is that a pharmacist is employed and integrated into the RAF care team, and they work collaboratively with GPs and prescribers, allied health professionals, including dietitians, OTs, speech pathologists, and the community and hospital pharmacists. Residents, family members and carers are involved in decisions about residents' medications. The pharmacists conduct regular audits to identify residents most at risk of medication-related harms, and on-the-spot medication reviews can be conducted when residents return from hospital, when they enter the facility, at transitions of care, such as when they are diagnosed with a new condition or they commence palliative care. So the pharmacist can contribute to improving policies and procedures, particularly in response to problems that arise, patterns in medication incidents, etc. The pharmacist can provide education to individual and group RAF staff, as well as residents and family members, and this includes assessing care staff's medication administration competencies. So the pharmacist can optimise medication rounds to find efficiencies, and they can coordinate and or conduct vaccinations. So in terms of other pharmacist-led interventions in residential aged care, Ibrahim and Miranda have both conducted some reviews in this area, and there is not a great deal of interventions in the literature. The interventions tend to be focused on conducting medication reviews of residents' medications, and there is some limited multidisciplinary collaboration and communication with GPs, nurses and other health professionals, and involvement of residents and families. So I think the limitations of the current interventions and models is that they're focused on medication review and that there's limited level of interprofessional collaboration. So our current study will have public findings available in November, so I can't yet comment on the effectiveness of our study, but what we identify the potential impacts to be improvements in the quality and safety of medicine use by RAF residents. We're hoping to produce some evidence about integrating a new role into RAFs that can inform policy development. And Miranda, in her work on the evaluation, is specifically looking at collaboration and implementation. And the model of having pharmacists in facilities can address workforce capacity issues that RAFs and primary care are facing. And for pharmacists, it develops and expands the pharmacist role. So in terms of the funding models, we have some facilities in the ACT who have decided to fund the pharmacist role themselves after the 12-month intervention has finished. And the Department of Health's 2022 budget announcement did announce a commitment to pharmacist services, but there's been no further details or further, I think this week there was a lot of announcements about some funding in aged care, but pharmacist services weren't included in that. So I'd like to end with a case study that shows the kind of work that our pharmacists are doing in facilities. So we had a situation where a resident had dementia and type 1 diabetes and was refusing blood glucose monitoring, which is a finger prick and insulin injections. And what the pharmacist did was actually talk with the family and GPs. RAF staff were not available, that were not familiar with BGL monitoring, which is a patch sensor. It also involves a bit of cost, and having decided that this would be a good idea, the pharmacist ordered and set up the BGL monitoring skin patch. They had to train staff in how to use the skin patch and provide ongoing support to the care staff so that when the patches needed changing. So the outcome of this was that the resident seems to be more comfortable, they're not refusing insulin injections, and that it shows how on a resident level, on a RAF level, and in terms of the timely intervention allowed for broader changes in the RAFs, the education with staff, and a reduction in medication incidents that would have arose out of the medicine refusal. So that ends my presentation, and it would be really good to actually hear also from the workers and management staff from RAFs about how the benefits and limitations and their experience of working with allied health, including the on-site pharmacists. So thank you for your time.
So thank you very much, Jane, for very informative presentation. And it's interesting to see across all the presentation, you can see how different areas of health can be supported by different allied health professionals, and how the work of different allied health professionals can together integrate and produce like an enhanced outcome for our residents. So that really accentuates what Stephen has presented earlier in the day of the multidisciplinary team care. And that's just my learning today. And I feel so impressed with all of the information presented on how detailed and specifically can different allied health can contribute. So our last presentation today, but not least, is introduction about health pathways. So why we include the health pathways presentation here today? Health pathways is a platform that can help originally designed to support GPs to navigate the aged care system, to help GPs know where to refer people to for different health conditions and services. And now we would like to expand the scope and just, welcome more users from different allied health disciplines, from facilities that, can somehow help support the referral for allied health professionals. So please welcome Morgan for our GPs and GP clinical editor for the health pathways to present about health pathways. Thank you.
Thank you very much. My name is Morgan. I'm a GP who works in Canberra, but I also work for Capital Health Network.
Yeah,
we've got a website that's called Health Pathways. And it is a site of clinical information. So Health Pathways is a website of clinical health pathways, and it's supposed to provide point of care, clinical guidelines, and referral information for primary care. Mostly it's been used by GPs, but it is actually accessible to anyone who's working in primary care. So that includes all of allied health. You've all got some stickers on the center of your table. So if you've been wondering what those are, they're not bumper stickers. Please do not stick them on the bumper of your car because they've got a username and password on there. But it's a generic username and password, and you can pull out your phones now if you like, and you can go to ACT South New South Wales or actsnsw.communityhealthpathways.org, and the Together and for Health username and password will let you log on. This is a project that started in New Zealand in 2008, but it's since spread to Australia and the UK. And like I said, it's localized. So different regions actually all maintain their own version of the Health Pathways website. So there's 32 different regions in Australia, 11 in New Zealand, and 3 currently in the UK. They're the most recent site that it's metastasized to. The pathway components. So we have clinical pathways that include assessment and management, but we also have service and referral pages that talk about what services are available in a local area. New pathways are made. We try to make them evidence-based. They're usually drafted by a team of GPs, but then we try to get agreement between subject matter experts, which can either be specialist physicians or they can be allied health professionals who work in that particular area, or others, and the GPs on how the condition is best managed and what the best referral pathways are. And then we do review the pathways as well, and we review them based on both the level of use and the time since they were last reviewed, and how time sensitive a particular topic is. So if it's something like COVID-19, it's almost continually under a state of review. And then there are other pathways that are reviewed once every couple of years. So this is the local health pathway area. It contains ACT and the surrounding South New South Wales region. There are the login details, but you've got your stickers that contain them as well. And then I am going to try a bold experiment and try and get out of this show and open up the web browser. So usually you can just type the health pathways into Google and then Together for Health in the username and password bar, and that will let you sign in. We won't save any pathways here. So this is the website. Two ways of finding the information that you want. Well, first, it brings you to our news page. So the news page will both tell you about current health alerts in the region, and it will also contain recently updated pathways. And then there's a list of local, of useful links for local services down the side as well. On the left-hand side, there's a table of contents. So if you wanted to know something about older adults' health, for instance, you can bring up a table of contents for that subject, and then you could look at things like older adults' health assessments, and then this will contain clinical information like assessment and management, and then you can link off to referral information down the bottom of the page. But there's also a search bar up the top. So if you were wondering about diabetic foot care, for instance, you could just start typing in diabetes up the top. It will automatically bring up a list of related topics, and then you can just open it up that way. So I was saying that there are two different kinds of page. There's the clinical pages, and then there's also the referral pages. Having determined that your patient with the diabetic foot might need some podiatry care, you can then go to pages that don't contain any clinical information, but they do contain sort of a business directory or services directory for both public and private resources. So in the news, in ACT, for instance, you can see that you can refer to ACT Health, but down the bottom, you can also click on private, and it's got a service directory for some of the private podiatry providers in the ACT. If there are any podiatrists in the room and they're saying, hold on, we're not listed on that, it's because we don't know that you exist. So if you work in allied health and you'd like to be on health pathways, we'd love you to be there. Just reach out and let us know that you exist, and we're happy to update the list to include your service. There are multiple ways of contacting us. Down the bottom of every page, there's this speech bubble in the blue circle for sending feedback. You can just click on that, and then you can enter your email address. A box will pop up for you to type your comments, and you can say, I'm providing this service within ACT. I'd be interested in being listed on your service directory. Yeah. We also have a email address that you're welcome to contact us at healthpathways@chnact.org.au. And you're also welcome to talk to myself or my colleagues who work with Health Pathways as well, Jeanette and Sharon, who are sitting down the back during the lunchtime period as well. Thank you very much.